Welcome to our lecture on Restorative Interrelationships, Biologic Width Violations. In this session, we'll explore key aspects of biologic considerations in restorative dentistry, focusing on margin placement and the concept of biologic width. We'll cover the importance of evaluating and correcting biologic width violations, providing guidelines for margin placement, and discussing clinical procedures. You'll learn about tissue retraction techniques, provisional restorations, and ensuring a proper marginal fit. Additionally, we'll touch on crown contour, managing subgingival debris, and dealing with hypersensitivity to dental materials. By the end of this lecture, you'll have the knowledge to manage biologic width effectively, ensuring successful and lasting restorations. Let's dive in. Periodontal health and tooth restoration are inseparable for long-term success. Restorations must be managed to prevent periodontal disease and ensure compatibility with periodontal tissues. Key management areas include marginal integrity, contour, biocompatibility, occlusion, and maintenance. Aesthetic and functional harmony between restorations and periodontal tissues is crucial for patient satisfaction and oral health. Biologic considerations in periodontal restorative relationship. Margin placement and biologic width. Understanding the periodontal restorative relationship. The location of the restorative margin relative to the adjacent gingival tissue is crucial. The concept of biologic width is key to maintain healthy gingival tissues and proper gingival form around restorations. Biologic width. Definition: the combined width of the junctional epithelial attachment and the connective tissue attachment. Measurements: connective tissue attachment, 1.07 mm above the crest of the alveolar bone. Junctional epithelial attachment, 0.97 mm below the base of the gingival sulcus. Total biologic width, 2 mm. Importance of biologic width. Ensuring the biologic width is maintained prevents inflammation and preserves periodontal health. Violation of the biologic width leads to gingival inflammation and possible loss of attachment. Average human biologic width: connective tissue attachment 1 mm in height, junctional epithelial attachment 1 mm in height. Sulcus depth of approximately 1 mm. The combined connective tissue attachment and junctional epithelial attachment, or biologic width, equals 2 mm. Margin placement options. Supergingival margins. Location: above the gingival tissue. Periodontal impact: least impact, easier to clean and less likely to cause inflammation. Aesthetic considerations. Traditionally used in non-aesthetic areas due to contrast with traditional materials. Modern materials, translucent restorative materials, adhesive dentistry, resin cements, allow for supergingival margins even in aesthetic areas. Equigingival margins. Location: even with the gingival tissue. Periodontal impact: previous to retain more plaque. Modern techniques mitigate this concern. Aesthetic considerations. Concerns about unsightly margin display due to minor recession are less relevant today. Can be polished to blend aesthetically with the tooth. Tolerance: generally well tolerated periodontally. Subgingival margins. Location: below the gingival tissue. Periodontal impact: greatest biologic risk due to difficulty in access and finishing. Risks: harder to maintain hygiene. Potential to violate the gingival attachment if placed too deep, leading to inflammation. Indications: should be used cautiously, primarily when aesthetics necessitate. Diagnosing biologic width violations. Criteria: restoration margin placed 2 mm or less from the alveolar bone. Gingival tissues are inflamed without other evidences. Clinical signs: inflammation and gingival recession. Conclusion: understanding the biologic width and careful margin placement are essential for optimal periodontal health and successful restorations. Modern materials and techniques allow for more flexibility in margin placement, maintaining periodontal health. Supergingival and equigingival margins are generally safer and well tolerated, while subgingival margins require careful management to avoid biologic width violations. Importance of margin placement in restorations. Reasons for subgingival margin placement. Restorative margins may need to be placed below the gingival tissue crest for several reasons. Resistance and retentive form. To provide adequate mechanical retention for the restoration. Contourations. To address significant tooth deficiencies, such as those caused by caries. Aesthetic masking. To conceal the tooth/restoration interface for a more natural appearance. Biologic width violation. Definition: placing the restoration margin too far below the gingival tissue crest, impinging on the gingival attachment apparatus. Consequences. Impingement on the biologic width leads to periodontal issues, including inflammation and bone loss. Responses to biologic width violation. Bone loss and gingival recession. The body may resorb bone and cause gingival recession to re-establish the biologic width. This response is more common in areas with thin alveolar bone. Contributing factors. Trauma from restorative procedures. Gingival thickness and type, thin and fragile versus thick and fibrotic. Gingival form, highly scalloped versus flat. Thin, highly scalloped gingiva is more prone to recession compared to thick, flat gingiva. Persistent gingival inflammation. Common when the bone remains unchanged, but inflammation persists due to margin proximity to the bone. Management. Surgical intervention, altering the bone level surgically to create space for reattachment. Orthodontic extrusion, moving the tooth and restoration margin away from the bone to establish the necessary space. Ramifications of a biologic width violation if a restorative margin is placed within the zone of the attachment. On the mesial surface of the left central incisor, bone has not been lost, but gingival inflammation occurs. On the distal surface of the left central incisor, bone loss has occurred, and a normal biologic width has been re-established. Clinical management of deep margin placement. Surgical options. Gingivectomy or osseous surgery to re-establish biologic width. Orthodontic techniques. Extrusion of the tooth to reposition the margin appropriately. Conclusion. Subgingival margin, though often necessary for functional and aesthetic reasons, must be carefully managed to avoid violating the biologic width. Understanding the body's response to margin placement helps in choosing appropriate interventions to maintain periodontal health. Both surgical and orthodontic solutions can be employed to address issues arising from deep margin placement, ensuring long-term success and health of the restorations. Biologic width evaluation. Identifying biologic width violations. Radiographic interpretation. Interproximal violations. Radiographs can identify biologic width violations between teeth, interproximal areas. Not effective for messiofacial and distal line angles due to superimposition of tooth structures. Clinical signs of biologic width violation. Tissue discomfort. Discomfort when probing around restoration margins indicates possible biologic width violation. Suggests that the margin extends into the attachment area. Clinical assessment of biologic width. Probing technique. Use a sterile periodontal probe to measure the distance from the bone to the restoration margin. Procedure involves anesthetizing the area and inserting the probe through the attachment tissues to the bone. Measure the distance. If less than 2 mm, a biologic violation is confirmed. Perform circumferential measurements around the tooth to assess the extent of the violation. Personalized biologic width assessment. Sounding to bone. Method: probe to bone level and subtract the sulcus depth. Perform on multiple teeth with healthy gingival tissues for accuracy. Significance. Determines individual patient's biologic width. Helps in diagnosing violations and planning restoration placement. Clinical applications. Diagnosing biologic width violations. Measure the bone to margin distance. Confirm violations if the distance is less than 2 mm. Planning for future restorations. Use individualized biologic width methods to guide margin placement. Ensure restorations are in harmony with the patient's gingival tissues. Conclusion. Proper evaluation of biologic width is crucial for periodontal health and successful restorations. Both radiographic and clinical assessments are necessary, with a focus on analyzed measurement techniques. Understanding individual variations in biologic width allows for better diagnosis, treatment planning, and long-term outcomes for dental restorations. Correcting biologic width violations. Correction methods. Surgical correction. Procedure: surgically remove bone to increase the distance between the bone and the restoration margin. Advantages. Rapid correction can result in a more aesthetically pleasing tooth length. Procedure details. Bone should be removed by the measured ideal biologic width for the patient plus an additional 0.5 mm as a safety zone. Risks. Potential for gingival recession. High likelihood of papillary recession if interproximal bone is removed, leading to an unaesthetic triangular space below interproximal contacts. Orthodontic extrusion. Indications. Biologic width violations on the interproximal side. Violations across the facial surface with correct gingival tissue level. Method: gradually extruding the tooth to move the restoration margin away from the bone. Orthodontic extrusion techniques. Low orthodontic extrusion force. Process. Slowly erupts the tooth, bringing alveolar bone and gingival tissue with it. Extrude the tooth until the bone level is coronal to the ideal level by the amount needed for surgical correction. Stabilize the tooth in the new pin. Perform surgery to correct bone and gingival tissue levels. Rapid orthodontic extrusion. Process. Tooth erupts to the desired amount over several weeks. Perform supracrestal fibrotomy circumferentially around the tooth weekly to prevent tissue and bone from following the tooth. Stabilize the tooth for at least 12 weeks to confirm the position of tissue and bone. Correct any coronal creep surgically if necessary. Patient history. Fractured left central incisor restored 12 months ago. Unhappiness with the appearance of tissue surrounding the restoration. Radiographic findings. Biologic width violation on the mesial surface interproximally. Treatment considerations. Concerns. Removal of interproximal bone could create an aesthetic deformity. Aesthetic deformities include papillary recession and the formation of an unaesthetic triangle below the interproximal contacts. Orthodontic extrusion as preferred treatment. Indications for orthodontic extrusion: preserves aesthetics by avoiding the removal of interproximal bone. Corrects the biologic width violation by moving the tooth and margin away from the alveolar bone. Orthodontic extrusion procedure. Steps involved. Low orthodontic extrusion force. Slowly erupts the tooth, alveolar bone and gingival tissue with it. The tooth is stabilized at the new position, and subsequent surgical adjustment corrects the bone and gingival tissue levels. Rapid orthodontic extrusion. Erupts the tooth quickly over several weeks. Weekly supracrestal fibrotomy prevents tissue and bone from falling tooth. Tooth stabilization for at least 12 weeks ensures the tissue and bone position is maintained. Expected outcomes. Benefits of orthodontic extrusion. Maintains or improves aesthetic appearance by preserving gingival architecture. Corrects biologic width violations with compromising interproximal bone and tissue levels. After orthodontic eruption. The tooth has been erupted. 3 mm to move the bone and gingiva coronally, 3 mm on the left central incisor. It is now possible to reposition the bone surgically to the correct level and position the gingiva to the correct level, re-establishing normal biologic width. 1-year recall photograph after orthodontic extrusion. Osseous surgery and placement of a new restoration. Clinical considerations. Choosing the correction method. Surgical method. Preferred for faster results. Suitable when crown lengthening will enhance aesthetic appearance. Orthodontic method. Preferred to avoid unaesthetic spaces due to papillary recession. Appropriate for specific cases where maintaining gingival tissue levels is crucial. Post-procedure care. Ensure the tooth is stabilized adequately after extrusion. Monitor for any coronal creep and address it surgically if needed. Regular follow-up to ensure periodontal health and stability of the restoration. Conclusion. Correcting biologic width violations is essential for maintaining periodontal health and the longevity of restorations. Surgical removal of bone and orthodontic extrusion are effective methods, each with specific indications and potential risks. Individual patient assessment is crucial to the most suitable correction method. Proper execution and post-procedure management are key to successful outcomes. Margin placement guidelines. Using sulcular depth as a guide for margin placement. Assessing biologic width requirement. Use the patient's existing sulcular depth to determine the appropriate placement of restorative margins. The base of the sulcus represents the top of the attachment, ensuring the margin is placed within the sulcus and not in the attachment. Sulcular probing depth variations. Shallow probing depths, 1 to 1.5 mm. Extending the preparation more than 0.5 mm subgingivally risks violating the attachment. Periodontal probe penetrates about 0.5 mm into the junctional epithelial attachment in healthy gingiva. Low risk of future recession as the free gingival margin is close to the attachment top. Deeper probing depths. Allow more freedom in placing restoration margins farther below the gingival crest. However, deeper sulci increase the risk of gingival recession. Guidelines for margin placement. Managing gingival health. Ensure gingival tissues are healthy before determining margin placement. 3 rules for intercurvicular margin placement. Rule 1. Sulcus probes 1.5 mm or less. Place the restoration in 0.5 mm below the gingival tissue crest. Particularly important on the facial aspect to prevent biologic width violation. Rule 2. Sulcus probes more than 1.5 mm. Place the margin at half the depth of the sulcus below the tissue crest. Ensures the margin is covered even for patients at higher risk of recession. Rule 3. Sulcus greater than 2 mm. Evaluate the possibility of performing a gingivectomy to create a 1.5 mm sulcus. Treat the patient using Rule 1 post-gingivectomy. Rationale for Rule 3. Challenges with deep margin placement. Difficult to place margins accurately and predictably with a deep sulcus. Stability of the free gingival margin is less predictable in deep sulci. Sulcus depth reduction. Creates a more predictable environment for placing curvicular margins. Ensures restorative margins are not exposed and remain aesthetically pleasing. Note, gingival rebound may occur post-gingivectomy, which can affect the final sulcus depth. Conclusion. Using sulcular depth as a guideline helps avoid biologic width violations and maintain periodontal health. Properly managing gingival health and adhering to margin placement rules ensure long-term success and aesthetic outcomes for restorations. Regular assessment and individualized treatment planning are crucial for effective margin placement and periodontal maintenance. A 78-year-old woman presents with the maxillary anterior. Restorations placed 6 months earlier. She is unhappy with the exposed margins and notes that the margins were covered the day the restorations were placed. Depth from the attachment to the level of the preparation. Margin is greater than 3 mm. This patient had an altered eruption pattern and a sulcus depth of more than 3 mm when these restorations were placed. 2 options were available to manage treatment appropriately. 1. Place the original margins to half the depth of the sulcus, in which case the recession that occurred would not have exposed them, or 2. Perform a gingivectomy, creating a 1 mm to 1.5 mm sulcus. The second option was chosen when the restorations were redone. The margins were then placed 0.5 mm below the tissue after the gingivectomy. Fourier recall photograph after placement of the final restorations for patient in Figure 66:10. Note the tissue level has been maintained, with a sulcus depth of 2 mm on the facial surface. Clinical procedures in margin placement. Margin placement techniques. Supragingival and equigingival margins. Procedure. Requires no tissue manipulation. Amount of reduction, incisally, occlusally, facially, lingually, and interproximally, is dictated by the restorative material choice. Subgingival margin placement. Initial preparation. Complete the preparation to the free gingival margin facially and interproximally before extending subgingivally. Use the margin of the tooth preparation as a reference for subgingival extension once tissue retraction is achieved. Tissue retraction. Retraction chords. Two-chord technique. First chord. Place in the sulcus to retract tissue vertically and create space. Second chord. Place on top of the first chord to further retract tissue and define the margin location. Impression preparation. Remove the top chord before taking the final impression, leaving the margin visible and accessible. The initial chord remains until the provisional restoration is completed. Electrosurgery. Technique. Use a fine wire electrode tip held parallel to the tooth, the margin in the sulcus. Move the tip through overhanging tissue to open the margin and expose the retraction cord. The electrosurgery tip sits on top of the retraction cord to control the vertical position and minimize tissue removal. Indications. Effective for Rule 2 situations with deeper sulci. Often required when the margin is 1.5 to 2.0 mm below the tissue crest to remove overhanging tissue without altering gingival tissue height. Clinical procedure steps. Supragingival portion preparation. Complete the tooth preparation to the free gingival margin before extending subgingivally. Tissue retraction with cords. Place the first cord in the sulcus to retract tissue vertically. Place the second cord to further retract tissue and set the final margin depth. For deep sulci, Rule 2 situations, use 2 larger diameter cords to deflect tissue adequately. Lower the margin to the top of the second cord before taking the impression. Place a third cord if necessary for deep sulci before the final impression. Electrosurgery for tissue retraction. Hold the electrosurgery tip parallel to the preparation. Use the tip to remove overhanging tissue while controlling the depth of retraction. Ensure minimal tissue removal by keeping the tip on top of the retraction cord. Conclusion. Effective margin placement relies on accurate tissue retraction techniques. Supragingival and equigingival margins are straightforward, while subgingival margins require careful tissue management. The two-chord technique and electrosurgery are essential for achieving optimal subgingival margin placement. Proper execution ensures margin visibility and ability for impressions, supporting periodontal health and restoration success. Using electrosurgery, the fine wire electrode tip is held parallel to the tooth preparation and rests on the cord as the tip is moved around the tooth. Provisional restorations. Importance of provisional restorations. To ensure a favorable biologic response during the interim period before final restorations, 3 critical areas must be managed. Marginal fit. Crown contour. Surface finish. Marginal fit. Impact on periodontium. Poor marginal fit can cause gingival inflammation. Inflammation level correlates with the degree of marginal opening. Consequences of poor fit. Large openings can harbor bacteria, leading to significant periodontal issues. Prevention. Ensure precise adaptation of provisional margins to avoid inflammation and tissue damage. Crown contour. Proper contouring. Ideal contours prevent gingival inflammation and promote tissue health. Over-contouring can cause inflammation, while under-contouring generally does have adverse effects. Common issues. Over-contouring often results from inadequate tooth preparation. Technicians may create bulky restorations to accommodate insufficiently prepared teeth. Clinical practice. Aim for a flatter contour where aesthetics are not critical to avoid periodontal complications. Surface finish. Surface quality. Provisional restorations must have a smooth, polished surface. Rough or porous surfaces can lead to plaque accumulation and gingival inflammation. Management. Ensure all provisional restorations are well polished and free from imperfections. Subgingival debris. Sources of debris. Retraction cord, impression material, provisional material, temporary or permanent cement can all be sources of subgingival debris. Consequences. Debris left below the gingival tissue can cause inflammation and adverse periodontal responses. Diagnosis and management. Use an explorer to examine the sulcus around the restoration for debris. Remove any foreign bodies and monitor tissue response. Tissue anesthesia may be necessary for patient comfort during debris removal. Summary. Effect management. Ensure provisional restorations have excellent marginal fit, appropriate contour, and smooth surface finish. Regularly check and clean subgingival areas to prevent debris-induced inflammation. Clinical outcomes. Properly managed provisional restorations maintain gingival health and set the stage for success of final restorations. Hypersensitivity to dental materials. Inflammatory gingival responses. Gingival inflammation has been reported due to non-precious alloys in dental restorations, especially those containing nickel. The frequency of hypersensitivity reactions to nickel-containing alloys is debated. Non-precious alloys. Non-precious alloys. Commonly associated with hypersensitivity reactions, particularly alloys with nickel. Precious alloys. Hypersensitivity reactions to precious alloys are extremely rare. Using precious alloys can mitigate issues encountered with non-precious alloys. Surface roughness and gingival response. Impact of surface roughness. Gingival tissues respond more to surface roughness than to the material composition. Rougher surfaces lead to greater plaque accumulation and subsequent gingival inflammation. Importance of a smooth surface. Smooth surfaces are crucial to minimizing plaque accumulation and inflammation. Subgingival areas of restorations must have smooth surfaces regardless of the material used. Clinical implications. Materials comparison. Porcelain, highly polished gold, and highly polished resin show similar levels of plaque accumulation in clinical research. Best practices. Ensure all restorative materials, especially those placed subgingivally, are highly polished and smooth to prevent plaque buildup and inflammation. Summary. Hypersensitivity management. Favor precious alloys to avoid hypersensitivity reactions. Prioritize the smoothness of restorative materials over the type of material to minimize gingival inflammation. Outcome. Achieving smooth surfaces on subgingival restorations is critical to maintaining periodontal health and preventing hypersensitivity reactions.